So thanks for having me here today. Thanks for having me here today. I'm a medical and molecular geneticist, and I'm going to try and give you a perspective from a couple different hats that I've worn. I've directed a clinical diagnostic laboratory where we did 110,000 samples per year, so I have a sense in terms of what it takes to be CLIA/CAP certified in doing that. I also have directed a research laboratory for the last 20 years in human genetics, so I have a sense of the differences in terms of what we do in terms of research, and have the pleasure of being the principal investigator for a new condition or a new study that we call SPARK, which is trying to do genomic research for autism on scale. And so I'll try and tell you some lessons that we've learned from that. So I'm not going to address the normative question of should we return results, but I am going to try and address some of the practical issues about if you return results, what are some of the opportunity costs that come to that? Because as I think some people said, there are real dollars that go to this, and try and put some numbers in terms of what it costs to do that. So as we've done this in terms of CLIA requirements, CAP requirements to be able to do this, it does come with a lot of additional quality control and quality assurance that we put in place in a clinical laboratory. And just to give you an example, for my last large-scale study where we were doing exome sequencing, we actually put out for bid the difference be able to do this in a research mode versus a clinical CLIA mode, and I think I got the best in terms of cost around the country to be able to do that. And there was a threefold difference in terms of the cost to be able to do this in a CLIA mode versus the research mode just for data generation. And so again, I think these costs will actually narrow over time, but there certainly is a difference in terms of being able to do that. The other part of this is the interpretation of the data, and I think in terms of being able to interpret that, it depends very much in terms of who's doing the interpretation and how much they know about the individual participant to be able to interpret those data. I think we will get to a point where you can do this on scale with a click of a button of being able to interpret this without clinical context, but we are not there yet for most things. And so in terms of doing that, the closer you are proximally to the patient and to being able to know those circumstances, I think the better your interpretation are. So when it comes to, for instance, some of the questions that were raised about biobanks, when you have secondary and even tertiary users of that, I think it becomes more difficult to be able to reliably and correctly interpret those data. The other portion of this to me is about, as the last panel was discussing, actually returning that information to the participant. And when you think about doing this responsibly, so in a way that people can actually use this information and hopefully understand it correctly and not misuse it, there is also a cost that comes with that. So although we've tried doing things that scale in terms of having things like, for instance, videos and online materials to talk about in general what these results mean, we have actually, in my studies, taken that we need to do this responsibly in terms of being able to give it to the individual person. And with this last study where we've done it nationally, we're actually using a group nationally of genetic counselors that have the opportunity to be able to return individual participants' results to them if they so choose to use that service. And just again, to put a dollar figure on that, that runs at about $250 per person to be able to do that and to do that on scale nationally. So, with this, I think one of the questions, again, for the group to be able to think about that is, as you're doing this, what are those costs to doing it? We've also thought about this question of, I think was raised, can you, at least for genomic data, actually just give the participant back their raw data and essentially leave that responsibility up to them? So whether it comes to services that are or will now be in the future available, things like Grail-like interpretive services, where an individual participant could pay to have their information interpreted, potentially iteratively over time as the knowledge base changes or as the clinical question changes. That's certainly something that at least we've thought about and thought about how to do. We have actually taken a policy in my studies that if a participant asked for their raw data, we would give it to them in a BAM format. So in other words, something where you could from the very beginning be able to take that and go to someone to be able to interpret those data. But the one concern that we've had in terms of thinking about that is that there does bring up the question of disparities. So not everyone can be able to afford those services that are now available or will be available. But again, I think I look forward to when those services are available. So just in closing with the opening remarks, I think one of the things is we can think about what we have now. What I like to do, though, in terms of more brainstorming, is think to what we should be able to build an infrastructure that will scale. So if we take the normative question first in terms of what should we do, what as a community, and I want to emphasize a community because it's a community of participants, researchers, physicians, providers, the community, what systems can we build to scale this so that some of the costs that I talked about can actually be driven down if that's what normatively we say we should be doing. And in an exciting way, I think there are opportunities to be able to scale that, but we need to think now about what it's going to take because it's not trivial to build those systems.